Доброго вечора, українські радіаційні онкологи. Слава Україні! Дуже дякуємо, що приєдналися до курсу Case Review with ASTRO Experts for Ukraine. Мене звати Наталка Ковальчук, я є Clinical Associate Professor в Стенфорді, і також я є співзасновницею і президенткою Help Ukraine Group або HUG. Разом з ASTRO International Committee ми організували цей курс на 12 лекцій раз в місяць по других вівторках місяця. Ось декілька організаційних моментів, я їх також поставила в чат. Щоб увімкнути синхронне субтитрування українською мовою, натисніть, будь ласка, Show Captions внизу, My Speaking Language English і Translation to Ukrainian. І це налаштування збережеться для майбутніх сесій Zoom. Ваша присутність буде зарахована відповідями на запитання інтерактивного опитування Zoom під час лекції. Будь ласка, активно відповідайте на запитання під час лекції і переконайтеся, що ваше ім'я Zoom є таким, яке ви хочете мати на друкованому сертифікаті про закінчення. Щоб змінити своє ім'я, натисніть Participants і біля свого імені 3 крапки змініть ім'я. Наприкінці курсу ви отримаєте сертифікат про закінчення курсу з кредитами, еквівалентними кількості відвіданих лекцій, помноженим на 1,5, тобто відвідуйте лекції. Формат лекцій наступний. 1 година лекції експерта ASTRO, презентація стандартного кейсу з 5 інтерактивними опитуваннями Zoom. І 10-15 хвилин – це доповідь українського експерта, складний кейс. І 15-20 хвилин – це в кінці запитання, відповіді аудиторії. Тобто, якщо у вас є запитання під час лекції, ви можете його написати у чат або тримайте його до кінця лекції після всього викладу. Я зараз буду переходити на англійську мову. Ви можете тоді перевірити, як перекладаються субтитри. Today's lecture is oropharynx cancer, and we have 2 great speakers for this topic. Dr. Dave Fuller, he is a professor at MD Anderson Cancer Center in Houston, Texas. For those who don't know, MD Anderson is one of the top cancer centers in the US and has been ranking the top one for many, many years now. Dr. Fuller is a well-known head and neck expert in the world with more than 430 publications, numerous educational mentorship awards, and countless research grants. In addition to his doctorate degree or MD degree, he also has a PhD in imaging physics. He is also board certified in both radiation oncology and clinical informatics. His research focuses on advanced computational modeling and imaging applications for head and neck radiotherapy with a focus on toxicity reduction and image biomarker implementation. Welcome, Dr. Fuller. And our second speaker is a Ukrainian speaker. She's well known in radiation oncology in Ukraine. Her name is Marina Sokolovska. She's an associate professor radiation oncology department at Shupik National Medical Academy of Postgraduate Education. And she's a chair of radiation oncology department at Lisot Clinic in Kyiv. She has more than 20 years of experience in radiation oncology and is considered one of the leaders in radiation oncology field in Ukraine. She's very active, organizing sessions and speaking at the national conferences and also abroad. We are very happy to have you both teaching us today. Dr. Fuller, the mic is yours.
Great, thanks, Natalia.
Just very quick, Dave, sorry. Hi, I'm Tamer Rifat. I'm the vice chair of the ASTRO International Committee. I just wanted to thank very much Natalia for the great efforts getting this together. I cannot thank Dr. Fuller enough for the super short, ultra short notice to come and give this lecture. So thank you very much. Our Ukrainian counterpart, Dr. And I'm sorry, excuse my pronunciation of your last name, Sokolovska. thank you very much for doing this. And let's start. Sorry, Dave, you can, it's all
Oh,
yours.
no worries, Tamer. I didn't know you will be joining, but
Let's start.
Tamer actually helped to find the great speakers for this course. So we are very, very grateful from the whole of Ukraine. We say thank you to Tamer for agreeing to run this project and to find amazing speakers for this course. Thank you so much.
Thank you guys so much. You know, Tamer and I have been friends for a really long time, and I'm thrilled to work with Natalia and Marina on this exciting effort. I am going to start with all of the presentation is going to be available on Figshare, because I talk incredibly fast for an American even. And so if you miss something, all of these slides are available to you at any time publicly. And then you can match this to recording if needed. I'm going to show you my funding acknowledgements and disclosures faster than you can read them. But we're going to start with a kind of indicative case. So when a case comes up, we're often asked as you know, radiation oncologists, okay, you have this presentation, you've got this, in this case, this is a patient who walks in with an ulcerated tonsillar lesion, 4.5 centimeters. There's extension to the glossopharyngeal sulcus. You have 3 FD-avid right level 2 lymph nodes. And I think we can all appreciate that we see cases like this on PET or CT or MRI. And the question is, okay, it's too big for surgical resection with transoral robotic surgery. Probably not a great candidate for consideration of de-escalation. But if you just had this anatomic information, what do you do? What's the right therapy? And there's lots of different options that are considered kind of standards in the United States that might be applicable to this patient. 70 Gray and 35 fractions, 6 days a week with 100 milligrams per meter squared cisplatin every 3 weeks. Some patients, some folks might say 66 Gray and 33 or 30 fractions of radiation only. Some might say 69-96 in 33 fractions with weekly cisplatin. Some might say 70 and 35 with concurrent cetuximab. What's the right answer? With this anatomic information alone and oropharyngeal cancer, I wouldn't be able to give you a good recommendation. Because if this was a patient who had HPV negative disease in a high tobacco history, then I would really advocate for concurrent cisplatinum-based regimens over those that aren't. If I had a patient who had HPV positive in a never smoker with a history of renal failure, I would be thinking about RT alone options and considering fractionation regimens or cetuximab. So what the right information is and what the right radiation plan is for these patients depends immensely on a lot of contextual information over and above just the location of the tumor. And we'll talk about how those considerations come into play. Now, for this patient, this is just an, kind of a teaser. This is an example of how we would take that information on the PET scan. We would perform a simulation CT. At our facility, we also leverage concurrent in-mask MR information a lot for these delineations. But the entire treatment process requires consideration not just of oropharyngeal cancer as an entity, but is in fact a very complex representation of the patient. And how we would treat or our treatment methods would also depend on what we see on the PET, what we see on the MRI. And then as we go through treatment, we see things like, how is the patient changing over the course of treatment? So we'll talk about how do we think about things like the patient's initial volume of disease and initial situation versus in week 2, where we see that there's substantial weight loss and substantial changes in the volume of disease. So as we move through time, these patients can have significant alterations. So even the patient you see at the beginning of treatment decision is not the same patient you're seeing as you go through therapy. Oropharyngeal cancers as a general class are exploding in the United States. They are becoming epidemic. So while we're seeing a great reduction in hard palate, lip, floor of mouth, soft palate, uvula cancers historically associated with tobacco exposure, we're really seeing an explosion of these, oropharyngeal, tonsillar, oropharynx type cancers in the U.S. Several years ago, it became clear that these were the dominant rationale for this was an explosion in HPV positive cancers in the US. And now HPV positive cancers far outmatch other cancers in terms of growth of incidence. And there are far more HPV positive oropharyngeal cancers than HPV negative. In our sitting, we're a tertiary academic center. 90% of our patients with oropharyngeal cancer are HPV positive or HPV associated. This really is something that's a big issue, and despite efforts at vaccination, HPV incidence isn't going to drop anytime soon, and the oropharyngeal cancer incidence isn't likely to drop until about 2050 in the United States. This HPV frame shift has meant that we've seen a significant paradigm shift in how we evaluate and care for these patients. And that's because going back to 2010, Kian Ang showed in the RTOG 0129 sub-analysis data set that receiving the same chemotherapy and radiation with platinum regimen, HPV positive patients had substantially better survival than HPV negatives. They had substantially better progression-free survival. And so what this has meant is that realization that these are two radically different profiles in terms of expectations of cure has meant that as of 2018, HPV positive oropharyngeal cancer is in fact recognized as a distinct disease. So our T staging is different. Our HPV clinical nodal staging is different. HPV positive pathological staging is different, but more importantly, our risk assessment for these patients is radically different. So that is to say that even locally advanced disease in HPV positive patients is expected to come with extended survival. That extended survival means that even though we might be applying historically developed treatments like chemoradiation therapy, these patients have a survivorship profile and a long-term risk profile that is much more oriented towards toxicity reduction or toxicity mitigation in survivorship than it is disease eradication at the cost of toxicity. And that's a very different paradigm than we've had in head and neck cancers historically. So going back to the pre-HPV era, if we look at Pierre Blanchard's work, we've found that the dominant paradigm that is associated with maximally improved disease control. So before we start talking about toxicity, if we want to eradicate disease in oropharyngeal cancer patients, it's quite clear that maximal therapy of chemotherapy and radiation represents the greatest probability of disease recurrence prevention, if you will. And overall survival, event-free survival from the mock meta-analytic group, which took individual case data from large numbers of clinical trials, show that there is a demonstrable improvement in the hazard ratio with the addition of chemotherapy, and chemotherapy is a broad class. So we'll start with our first kind of little question here. A patient has HPV positive disease with multiple lymph nodes, that first case we showed before, and a 15-pack-year smoking history. So a patient group we would define as intermediate risk. What is the least desirable therapy schedule combination that you would want? Not the most desirable, what's the one you would want to not do, right? So what is the least desirable, the least attractive based on the data?
To see the full answers to the poll, you can hover over with the mouse. And please answer because we will be taking your attendance with your answer. So I could see around 50% answering. So we'll wait to approximately 95% answering.
So remember on this, you're not trying to pick the winner, pick the loser. Pick the one you would not want to get. Yeah, I think we topped out in terms of our participation.
So we have 73% right now, so waiting for more answers, please.
Okay.
Будь ласка, відповідайте на запитання через те, що ваша відвідуваність буде залежати від ваших відповідей. І щоб побачити повністю всю відповідь, ви можете мишкою навести на, наприклад, опцію А, Б, С і так далі. І запитання у пацієнта HPV, поліноадальне захворювання та 5-річний стаж куріння, який режим комбінація терапії є найменш бажаною? Тобто, що б ви не зробили у своїй клініці? Okay, so we have 73% answering. I'm gonna end the poll and share results. Do you want to comment?
Yeah, so we would say in the United States, you want to not use cetuximab unless there is a compelling reason not to give platinum, right? So the first three use a variation of acceptable fractionation schedules and acceptable cisplatinum schedules. The last is cetuximab, and we'll talk about why we kind of feel that way. So platinum is the kind of historical, traditional standard of care for concurrent chemotherapy. It's been delivered effectively weekly across a huge numbers of regimens and cycles throughout the years. At the same time platinum was coming into play, there was an interest in cetuximab because it showed a difference in improved survival compared to radiotherapy alone. So local regional control was improved on what was called the Bonner study in 2006. Overall survival was improved compared to radiation alone. So in a case where your choice is radiation alone or cetuximab, we would preference cetuximab in patients who couldn't receive it. However, what was investigated recently in the United States was a study comparing cetuximab versus cisplatinum, and our intent was to show that cetuximab wasn't any worse than platinum. It was a non-inferiority study. But the problem was it was worse. So when we looked at overall survival was significantly reduced if you used cetuximab and IMRT compared to platinum and IMRT. And if we look at, this is progression-free survival, even worse results, quite poor. And if you look at local regional control, obviously the cisplatinum arm did much better in terms of a lower rate of local regional control. Local regional control, progression-free survival, and overall survival were all better with cisplatinum. And so for HPV positive patients who are eligible for concurrent chemotherapy, platinum should be given should be given rather than cetuximab, if at all possible. Now, if you have a patient who can't receive cisplatinum because they already have hearing loss or they have renal issues, cetuximab is better than radiation alone, but it's not better than cisplatinum and not comparable. This is really something that I think is important because not only did we see that there was not an improvement in there was a decrement in local regional control, in worse progression-free survival, worse outcomes. Again, no toxicity difference was observed either. So it wasn't better in terms of side effects. It wasn't a better treatment by any reasonable metric. So because of that, we would say that the standard of care for these kinds of patients is concurrent cisplatinum plus IMRT, at least domestically in the United States, unless there's a reasonable contraindication. One big difference, I would say, between Europe and the United States is we are much more willing to give elderly patients platinum or cetuximab. So in many countries at 75, they won't give concurrent chemoradiation. In the United States, we routinely treat any patient that's physically fit enough to tolerate that therapy. So it's a very important topic. Okay, so now kind of going back to that case, if we had this patient walk in, and we're starting a workup and we're starting to evaluate the patient, what other information in your radiation planning, other than the extent of disease on imaging, would you want to know? So our next question is, which of the following is not something that you would expect to do for every oropharyngeal cancer patient?
Okay, we see 77% answered. So please answer the questions. You know it or you don't know it. We will be taking your attendance with your answers. Please answer. So we have 81% answering. I'm ending the poll and sharing results.
Great. So, so interestingly, the thing that we would say is not standard of care for all patients is C, serum cell-free HPV DNA. Why is that? Because not all patients need serum HPV cell-free DNA, only those patients who have HPV positive disease on pathology. Moreover, the patients who we give these cell-free DNA tests, these are FDA approved, but we don't really know what they mean in terms of evaluation of either freedom from disease or disease recurrence. So the ones that are A, B, and D are all considered, at least at our facility and many others, to be standards of care. Why is this the case?
Yeah, Dr. Fuller, can you comment on the last answer? Because most people actually answered D.
That's
barium
correct.
swallow, yeah.
So in the US, speech pathology assessment with modified barium swallow and video fluoroscopy is considered a standard of care evaluation. And it's considered a standard of care evaluation because, as you'll see as we move forward, it allows us to evaluate the baseline swallowing function so that we can understand whether the patient will have high risk of late dysphagia after treatment. Because the majority of these oropharyngeal cancer patients are expected to have long survival, they actually have a higher risk, at least in the US, of having aspiration pneumonia after therapy than they do of their disease recurring. So because of that, it's important to evaluate what the swallowing function is pre-therapy. If a patient has impaired swallowing pre-therapy, you also are not going to attempt to maintain continuous oral feeding because the patient already has impaired oropharyngeal function. If the patient has good oropharyngeal function, you're going to aggressively attempt to prehabilitate and prevent trade-offs on that. So this is our standard MD Anderson workup, right? Contrast head and neck MRI and CT or PET CT, a chest X-ray and the CT chest. All of these are considered ways of ruling out metastatic disease. So you would get an MR and CT and a chest X-ray in low-risk patients. If they're a heavy smoker, a head and neck MR or CT and a CT chest. And then PET CT is useful for both evaluating distant metastasis and occult nodal disease. Endoscopic examination we'll talk about is imperative. Pathologic confirmation, HPV positivity testing or P16 testing of the pathology sample is considered critical. Speech pathology evaluation with modified barium swallow and or video fluoroscopy. A dental evaluation for potential extraction of damaged or unsalvageable teeth that may be in the radiation field. Nutrition, serum lab examination. And then, of course, patients should be evaluated by head and neck surgery, medical oncology, and radiation oncology for a formal disposition of treatment. I won't belabor, physical exam is incredibly important because localization of tumor, especially with regards to subtle mucosal extension, is very critical. What you see on the imaging may not necessarily reflect what is evaluable on clinical exam. So one of the key things that we say is endoscopy is critical. This is a left-sided tonsillar cancer. You can see quite obviously, you can see it's demarcated. But if you look a little deeper, there was this small, not particularly visible on imaging lesion that we saw that was a second primary, non-contiguous primary in this patient's hypopharynx. So endoscopic exam is, we would say, incredibly important because the other piece of information that you get from this endoscopic exam is you can see that this is a very well lateralized tonsil and there's not particularly large amounts of involvement in the soft palate. So if you didn't have this thing on the hypopharynx, this would have been a patient that we treated with unilateral radiation, right? Significant changes can be seen because of these creeping mucosal lesions that we see in oropharyngeal cancers. When we demarcate head and neck cancers, it's also imperative that our exam considers the kind of core anatomic considerations, not just of the general external anatomy. So again, the subregions of the oropharynx are well known, but also as we localize these tumors, we want to think about where the tumor is in relation to these anatomic routes of spread. So for example, we treat a tonsillar tumor that's contiguous with the tonsil itself, and lateralized can be treated unilaterally. But if there's extensive extension onto the soft palate or extension onto the base of tongue, well, now that patient needs bilateral nodal radiation prophylactically. If we see that there's involvement onto the vallecula or from the base, tumor on the base of tongue, if it rolls onto the vallecula, well, now you've got to worry about the preepiglottic fat space. So understanding the anatomic relationships are very important. When we use the endoscopic exam, we're also really looking for is these relationships between anatomic landmarks. So what that means is when we look, we always say, where is the tumor? Does it extend from some substructure of the oropharynx across one of these relatively fibrous constraining barriers? And those can be considered the median glossoepiglottic fold, the pharyngoepiglottic fold, the pharyngeal constrictors, which form, which again are not visible on exam, but are visible on imaging. This posterior pharyngeal wall, you can see the palate-glossal and palatopharyngeal muscles that provide the architecture of the tonsil itself, and then the soft palate and the uvula as kind of transoral landmarks, as you can see here. So we map the tumor out very carefully, and then we work very hard to relate that to imaging. Anytime you're talking about both imaging and physical examination of the oropharynx, the key concept you have to keep in your head is that oropharyngeal cancers, their major kind of anatomic, landmark, notable kind of construct is the parapharyngeal space. All oropharyngeal cancers require consideration of the parapharyngeal space, which is this inverted pyramidal structure that goes from the base of the skull all the way down inferiorly to the cornu of the hyoid. So this is what the parapharyngeal space looks like in an artistic representation, but it's very, very easily seen on MR imaging as a fat space that sits in this area. So the superior margin of the parapharyngeal space is the base of skull. Inferiorly, it's the insertion at the cornu of the hyoid bone. Medially, the deep cervical fascia. laterally the deep lobe of the parotid investing fascia. The anterior margin is the investing fascia of the medial pterygoid, and then posteriorly the prevertebral fascia. When we think about the parapharyngeal space, it's also imperative to understand its relationship to the other adjacent head and neck spaces. So these demarcations or these borders mean that if you have a locally advanced tumor, that it has demonstrable routes of spread across or through these adjacent nodal areas. So a good example is you're always thinking about, in every oropharyngeal case, this parapharyngeal space. There's no border between it and the ipsilateral retropharyngeal space. So you're always thinking about the retropharyngeal space in oropharyngeal patients as well. But let's say you have a really big tumor that moves anterior into the retromolar trigone. Now you have to think about masticator space involvement. Or if you have a very high tumor that invades through the investing fascia and invades into the pterygoid, now you've got to think about considerations of the buccal space. What if you have a tumor in the base of tongue that goes over the glossopharyngeal sulcus, glossotonsillar fold? Now you have to think about oral cavity involvement. So it really helps us demarcate these subregions and these sub-areas at risk. When we think about then that anatomic extent, the next piece of the puzzle for us is P16 positivity. So in the US, patients who are P16 or HPV positive who have a single node less than 3 centimeters and have small volume disease, T1 to T2 on AJCC 8th edition, those patients are candidates for radiation alone. They probably don't need chemotherapy. They're also candidates for transoral robotic resection, which, as I understand, is not particularly widespread in Ukraine. So I won't belabor that. But essentially, these are the patients that you can consider the same radiation fields, but using RT alone. So standard of care for those patients is radiation only. There's a low intermediate risk group, and those are the ones that have multiple nodes less than 6 centimeters. And those are ones where you can kind of consider whether you're going to do concurrent systemic therapy or sequential therapy. In the US, we have almost all moved to concurrent radiotherapy. So there are some places that still do induction, but the side effect profile is so great and the toxicity reduction benefits are minimal that you're just getting extra side effects in what are often highly curable tumors. By comparison, our high-risk patient population are those who have either evidence of extracapsular spread on radiographic imaging, multiple nodes or positive margins after surgery, history of tobacco use, T3 or greater than N1 positivity. These are the chemo RT patients, and that's our kind of bread and butter. If you look at our outcomes, at least domestically, this kind of risk stratification seems to work very well. This is data from our facility. So if you look at outcomes in terms of how well these patients do, there's a definite relationship between the extent of local disease and cure. But if you look at the stratification of these patients by patients who are non-chemotherapy T1 to 2 or T3 to 4, you can see that the non-chemotherapy early stage patients do very, very well. Those patients who don't get chemotherapy in the more advanced group do worse, right? So there's a subset of patients you can get away with not doing chemotherapy with, but they're these low volume, non-smoker, HPV positive, limited amount of disease patients. If they have significant disease, T3, T4, you're hurting the patients if you don't give them chemotherapy in addition to the radiation. Okay, so thinking about sparing these organs at risk, let's go to our next question. What are some practical ways you can reduce organ at risk dose coverage?
Recording. Recording in progress.
Okay, I see 84% answered. 86%, few more answers if you can. Okay, I'm ending the poll, sharing results.
So I think everybody pretty well got this one. All of these are ways that we can practically reduce organ at risk incidental coverage. If we think about how we can improve delivery with the same prescription dose, same chemotherapy, what can we do that can shave some extra coverage off these unintended organs at risk? Well, one thing is conformal delivery. So sharper beam edges, conformal approaches, multiple beam angles, VMAT, all of those innovations are very helpful. The other thing we can do is we can reduce our margins through aggressive immobilization. One of the things that we do, and I'll show here, is we use a occipital immobilization customized to the patient, a intraoral bite block or stent so that they can't rotate their head even if they have weight loss in the device, and then a thermoplastic mask indexed at the shoulders. This does a great job of trying to keep that anatomy in the same place. We really like customized occipital or cradle-based immobilization systems, especially if they kind of come up on the patient, because that means that you're passively immobilizing the patient through gravity rather than using a standardized head rest that then you have to use a tight mask, right? Because as the patients lose weight, that pressure reduces and their ability to move in the mask goes up and your margins have to go up accordingly. So external immobilization really works well. The other thing is getting as much information in the mask as possible. So if you have an external CT scan and then you're trying to have an MRI out, you have a CT in the mask and an MRI done on a diagnostic machine, well, then you've got to worry about how close you are in terms of registration error. It's much easier if you just put the patient in the mask and get an MRI in the mask if at all possible. That's logistically difficult, but the benefit to the patient is your registration error is much lower. The same is true, though, that your registration error QA is also a function of your immobilization error. So a good example here is we're able to register structures in the oral tongue and be very accurate about where they are, because in this patient, we also have, as we'll see in a moment, an intraoral stent that's attached to the external immobilization. So we've immobilized the internal structures of the tongue, so the tongue can't move. They have a mouth stent that locks the patient in place. That stent pushes the anterior and superior maxilla out of the radiation field and locks them into the mask system. So these things work synergistically together. I won't belabor it, but there is a really great article that came out in 2020 about best practices for recommending image-guided radiotherapy. And I would highly encourage everybody, this will be in the slides, to read this because I have strong feelings about IGRT, and it's a great read. So with that, we'll move to our next little question here. Okay, I think we got 81%. That's pretty good.
So we got 85% ending the poll, sharing results.
Okay, so the answer is D. What different IGRT systems tell you are different things. And you have to calibrate your IGRT system to your immobilization platform for your patient population. So if you've got a great immobilization platform and you have really good IGRT systems that you've calibrated very well, you can use 2 mm margins. On the other hand, if you have bad immobilization and you don't have great masks and you don't have a good IGRT system, you're going to have to add more margin to account for that. So it's important to understand that there's no such thing as a correct answer outside of what your system has been demonstrated to show in your application at your center. So it's very appropriate to use big margins if you have more uncertainty, and it's very appropriate to use smaller margins if you have strong immobilization and strong IGRT expertise. So the different systems tell you different things. So we use KV X-ray when we're setting up patients like where we're worried about superior or inferior motion. KV X-ray is better for that. Cone beam CT is better for axial alignment or detection of weight loss, as we saw in the initial example. MR Linac, which we have as kind of a niche thing, is better for online kind of considerations. So those IGRT systems are also reflective of the fact that, like, when you're doing your initial simulation, as much information as you can acquire in the treatment position is useful. So this is the diagnostic imaging. This is great, but it's far less useful to me than all of the information that I've got in the mask. Our fundamental premise is what you want to do, though, is make sure that you understand how that information and the imaging is used. So at a lot of places in the United States, they'll take an outside staging PET scan, they'll register it to the CT scan, they'll draw a big margin on it. Like you see here, they'll say, okay, this is the same area that's hot on the PET. They'll put a margin on that so they don't miss. They'll put a PTV margin on that so they don't miss that, and then they're done, right? That is a very straightforward way to do target delineation, but it's not very artful in terms of minimizing the dose to the patient's normal structures. So we want to be a little more finesse than that. We want to be a little bit more aware of that. So what we recommend at MD Anderson is multi-physician review. We highly recommend that every head and neck case that you treat, you want the plan and the images, the segmentations and the contour reviewed by either another radiation oncologist or the treating surgeon, because you want to make sure that you're thinking about what you can cover and what you can spare. And we have, we're in a very unique position, but when we feel like we're pretty good head and neck experts, but even within our group, we routinely change 60%, 66% of our cases have some kind of change, and about a third are going to have like a big significant change. And these changes can mean everything from, like, we decide that, hey, you're over treating a contralateral neck that you don't need to, or you missed an area that you should have covered to protect the patient. It is always imperative that you're not doing this alone, and your quality assurance needs another physician to review your segmentations and the images that those are derived from. And if you don't have another radiation oncologist, use a surgeon who's familiar with the case. Really, really, really important. Now, when we talk about volume definitions for oropharyngeal cancer at our facility, we start with the GTV, which is the gross disease, the CTV, which is the margin around the GTV, and there's two different kind of approaches to this. The Danish group do a 5 mm margin on the GTV, and they do a 5 mm margin on the CTV, and that's very safe, and that's very, it's been shown to be, effective, not a wrong answer. We use an anatomic approach because we try and spare normal tissue or cover normal tissue. I don't think either one of those is wrong, but we'll kind of talk about how that's the case. What that means, though, is that the dosing you give to those regions is going to be a little different. I'll show you this slide of NCCN doses. This is available in the slide deck. There's a lot of variation in these in terms of this is what, is widely accepted around America, but I'll show you what we do at our facility. So for patients who are eligible for RT alone, those low-risk small patients, if they're very, very small disease and they have very, very small nodes, we will routinely treat to 66 gray and 30 fractions to give some slight hypofractionation for these small volume nodes. If they are getting RT alone for anything bigger than that, T2 or greater, larger nodes, more than a centimeter, we treat 6996 in 33 fractions. Slight hypofractionation, 2.12 gray per day. For any patient getting chemo RT, we treat 6996, 2.12 per day in 33 fractions. And that's just because from a logistic perspective, our group doesn't like doing the 6-day-a-week Dahanka style that is very common. Historically, we now treat with a simultaneous integrated boost throughout the whole treatment region, but historically we would do a conventional larynx block and then treat the lower neck using conventional approaches in the pre-VMAT era. So if you don't have VMAT, step and shoot can often overdose the larynx. And so we would do a split field with a hot match at the level of the larynx, and then do a conventional low neck matched to an IMRT upper field. It's kind of a historic way we did it, but that's very reasonable. RTOG 1016, which is the other way that many of us treat, is the same as the Dahanka style. That's 70 gray in 2-day daily fractions, 6 days a week, and then a sub-regional dose to 56 gray. Lower risk targets are treated to 50 to 52, and if a low neck is treated, you can get 44 in 2 gray to the low neck. So these are very conventional kind of treatments. Our institution, we treat 6996, 63 dose level, and 57 in 33 fractions to our high, intermediate, and low risk CTV volumes. Now, then the question is, how much margin do you need around a CTV, margin around a GTV? It varies immensely. The literature, some people put a centimeter. Most of us, what we do is we contour the local compartment around the GTV with about a 6 to 8 millimeter margin, and then we pull off the normal tissue to create our CTV high risk. CTV low risks then encompass the adjacent nodal levels that are at risk. So I don't think there's a right answer there, but you can see that these are dropping over time. The pre-IGRT era, typically we're talking about 1 to 2 centimeters of expansion because of that localization era. In the post-IGRT era, most Americans are moving towards around a half cm. So these are rapidly changing, but they're certainly the case. So what areas need to be covered in terms of these elective nodal regions with your low or intermediate dose? The risk of pathologic node involvement in oropharyngeal cancer, this is work by Candela and Sanguinetti, is what we kind of use internally. So if you have N0 disease, you probably don't need to cover level 1 or level 5 at all. If you have node positive disease, there's risk in level 1 and some risk in level 5. So this varies a bit depending on if there's node involvement. So again, risk at baseline of level 1B and level 5 is really quite low unless you have a big node in an adjacent level. So if you have a giant lymph node in level 2, you need to cover level 1. If you also probably, the bigger the lymph nodes you have, the larger the coverage needs to be of these adjacent lymph nodes. So our typical guidelines in terms of node coverage are, we cover the RP nodes, levels 2 through 4. We start coverage for node negative necks at the bottom of C1 for level 2. In node positive patients, we cover the retropharyngeal nodes and levels 1B through 5 with elective dose, and we begin the lateral coverage immediately 1 slice inferior to the mastoid. So I'll show you a kind of indicative, case. So here's a kind of case scenario of what this looks like. This is a 46-year-old 10-pack year smoker She had a small right-sided lymphadenopathy that you'll see here. You can see there's a small amount of fullness in the tonsil, but very subtle. And then right-sided lymphadenopathy, which was biopsied. This is the pre-exam under anesthesia CT. And you can see, again, just some slight tonsil fullness on the CT, which was really appreciated on exam in that right node. So what would we cover? Well, this is that tonsil GTV that you can, and this is driven by, this is to illustrate that what's being driven here is what we saw in examination, because there's really not a huge difference in terms of the fullness on the CT. So here's that patient with a tonsillar CT. So we would add a CTV1 to cover the tonsillar area at risk. You can see we're covering the whole parapharyngeal space. We're biting into the investing fascia of the pterygoid over here, and we're biting into the investing fascia of the parotid. We're going all the way down to the cornu of the hyoid, and that would be our CTV1 that would cover that tumor. So imagine if this patient did not have that lymph node. What we would have is we would contour a little differently if we were, let me pull this up here. So if the patient had a tonsillectomy and removed that tumor, we would then cover that same volume postoperatively, but we would also add a GTV2 or CTV2, which would cover the elective nodal region. And so you can see how that would cover, in this case, because the patient has some risk factors in the node, there would the elective coverage would cover this, and we would treat that node to 70. Now let's look at a slight variation on the case. Imagine instead of just being in the tonsil, now we're looking at a case where the soft palate and uvula are involved on transoral exam. So this is the difference. This is the area where clinical exam in this variant shows uvula and soft palate involvement. The GTV is a little different. What changes immensely, though, is now this patient requires contralateral nodal coverage with at least low dose in the contralateral parapharyngeal space, full coverage with some dose of that entire soft palate uvula architecture, and then the elective coverage on the ipsilateral and bilateral sides is tailored to the nodal disease. Here's another variation on the case. Instead of just being in the tonsil, imagine that there's base of tongue involvement. So now, instead of just being a tonsillar case that we would treat unilaterally, there's involvement of the base of tongue. What that base of tongue involvement would mean is now, again, we have bilateral coverage. We're not covering the uvula and soft palate in this case, but we are covering into the base of tongue with a substantial margin, and the circumvallate, you can see that the circumvallate papilla and behind are covered with some elective dose. And again, the nodal coverage is tailored depending on the node risk on that individual side. So you can see that very small variations in the location of the tumor lead to substantial differences in terms of how we would manage that patient population. So in kind of a final closing, I'll talk a little bit about Marina or Natalia. Do I have time, or should I close it down just so we have time for questions?
No, you have time. Go ahead.
Okay. So okay, you've segmented your plan. You've defined your lymph node levels. Now we're moving to radiation treatment itself and the management of the patient. Obviously, our major goal in radiation planning is minimizing dose to these normal structures. And there's tons of them, which really makes it a problem. So as we all know, the major benefit of IMRT was that we could just push dose off the parotids. So in the early days of IMRT, we spared the spinal cord, we spared the parotids, we pushed the dose everywhere else, and we were pretty happy because this led to large reductions in xerostomia. So this is the data from the Passport study from Chris Nutting. And as you guys know, when you treat with conventional radiotherapy, almost everybody has quality of life altering, crippling xerostomia. And that's exactly what we saw in the conventional group in the Passport study. But with just sparing the parotids and the spinal cord, Chris Nutting was able to show that dropped that to under 30% had moderate severe dry mouth at 2 years in the IMRT group. So what that's really did was that said, okay, great, this major problem, xerostomia, that everybody had has been addressed, not taken care of, but addressed. What that left was all the other side effects that we were also causing. So we were radiating all these other non-target structures of risk. One of the things that we worry about in our group is late dysphagia and aspiration. So if you look at head and neck cancer patients in the US, 30% of them are going to have an aspiration event. So many of our patients with oropharyngeal cancer are in some cases more likely to die from aspiration after radiation from damage to the swallowing architecture than they are from the index tumor, because we do a good job of curing HPV positive tumors. And it doesn't matter, even in the IMRT era, these rates are high. So we can expect that 25% or more of our patients are going to have chronic aspiration on modified barium swallow. What's important is the patients may not be able to detect that. So is that why that barium swallow before therapy is so important, so that when they come back, you can screen them again and determine whether they now have occult swallowing dysfunction. Because the cumulative rate of aspiration pneumonia in our patient population is 20%. This is a really big deal. So what are some potential methods to reduce post-radiation dysphagia? And this is what we'll kind of close on a little bit, is our discussion of management of this.
Згадали.
Great. Okay. All right. So the answer is all of the above. So because you're radiating that parapharyngeal space and you're radiating those posterior muscles, those are muscles that are critically involved in swallowing. If you're also radiating the base of tongue, you're also knocking out the mylohyoid and geniohyoid muscles that are involved in oral phase swallow. So these patients, because of tumor involvement and post-radiation injury, are at really high risk. Avi Eisbruch did some really clear work several years ago where he showed that there was a direct relationship between the dose of these pharyngeal constrictors and the risk of having aspiration or videofluoroscopic injury or quality of life, eating, or swallowing dysfunction. And what's been really exciting is Chris Nutting, the same guy who did the PARSPORT study, recently completed a trial last year where they said, we want to push dose off of the uninvolved pharyngeal constrictors and keep those under 50 gray. And what he did when he randomized patients to not sparing constrictors or sparing constrictors was there was a substantive and important improvement in these patients' capacity to swallow. Their composite swallowing indices really made a huge improvement in these patients. So anything you can do that is able to reduce the dose to those structures is really important. So we do things like, one of the ways you can spare these swallowing muscles anteriorly and posteriorly is intraoral stents. So if you can move the patient's tongue out of the way, you're moving all of the swallowing muscles out of the radiation field. But you're also opening the patient's mouth, and by flexing, you can kind of lateralize and open up this tonsil and then try and pull dose off the contralateral pharyngeal constrictors. So these stents have really kind of important implications there. Because we're so worried about these swallowing functions, evaluation at every visit is crucial. We always ask the patient, are you having problems with choking? Are you having problems with swallowing? And are you able to maintain nutrition? Do you have a wet voice? And we work really hard to minimize the symptoms on therapy, because patients who have high degrees of symptom on therapy are the ones who are at the highest risk of late dysphagia. Now, some of that is because they have the most advanced tumors. But what we do is we look at on-treatment management. Every patient sees a nutritionist every week. Every patient sees a speech-language pathologist before, during, and after therapy. We use these radiotherapeutic precautions to reduce dose to the structures. We use patient-reported outcomes to evaluate whether they're having swallowing problems, and we are aggressive about pain assessment and control. That's really important because we don't want to have PEG feeding. If we look at feeding tube placement, this is data from Nancy Lee and our group, we really want to drop the number of patients who have G-tube dependency. So back in 2013, we were putting about 60% of our patients were getting G-tube placement. That number is now less than 15% in our oropharyngeal cancer population. But part of that is because we really took work from, this is work from Shlomo Koifman and his group, where if a patient is within 1 week of the end of radiation or 2 weeks of the end of radiation, and if they do need nutritional support, we put in a nasogastric tube, which is reversible, rather than putting a permanent PEG tube. So we try and get them as far through radiation as we can without PEG tube placement. The reason for that is there is good data that suggests that PEG tube placement is not only associated with worse swallowing outcomes, but we have some internal data that suggests that if patients who become sarcopenic and they have a PEG tube placed, it actually decreases their overall survival. But if the same patients become sarcopenic and lose lots of weight, but they can maintain nutrition, their survival is maintained. The way that we do this at our facility is with an aggressive prehabilitation regimen where we use swallowing techniques. This is a great overview by David Rosenthal and Jan Lewin. We avoid unnecessary mucosal radiation to the larynx, the pharyngeal constrictors, optimize the radiation plans, minimize patient swallowings with xerostomia, cytoprotection, evaluation by speech-language pathologists, delay feeding tube placement as long as you can, and if you can use an NG tube, use an NG tube rather than a PEG tube. You want them swallowing all the time, and even if you place a PEG tube, you want to force them to swallow as much water as possible, optimize pain management, and set reasonable steps for recovery. In the kind of like closing our pain management algorithm, everybody has their own algorithm, but this is to us the one that we use. So if they have prior alcohol or drug issues, we send them to pain management. Otherwise, we start them on low-dose gabapentin before they even start radiation therapy, and we bring them up to 900 milligrams TID as fast as they need to. We go as high as 3,600 milligrams total dose. We give them lidocaine before meals, and then once they have frank pain or weight loss greater than 2 kilograms, we begin analgesics, walking from tramadol to hydrocodone, hydrocodone to dilaudid, dilaudid to methadone, methadone to morphine, with fentanyl patches overlaid. And this is incredibly important because we have good data that shows that aggressive gabapentin use decreases their opioid utilization and helps with their nutrition. Better nutrition reduces mucositis. Reduced mucositis leads to better nutrition. So in the same sense, if you can spare the mucosa, they can eat better. If you can keep them eating better, their mucosa heals better, and they do much better. So I'll end by just showing our post-therapy surveillance. Patients come in at 3 months for a standard reevaluation with imaging, stroboscopic exam, modified barium swallow, and dental assessment. And they're followed on thereafter on an approximately 3 to 6 month basis for the first 2 years, and once a year after that with fixed visits. But all the way across, every provider is looking for signs of swallowing dysfunction, signs of aspiration, signs of trismus, signs of dental sequela like osteoradionecrosis, so that those patients can be triaged to the appropriate provider. So I've gone a little over time, but I thank everyone for the opportunity to speak with y'all. I know we've covered a lot of information, and I'm happy to take any questions after Marina's talk.
Thank you so much, Dave. That was excellent lecture. We learned a lot, and this is, as you said, a lot of material, but these lectures are also recorded, and we will be sharing the links with the recording, and these lectures will be also subtitled into Ukrainian and posted on the Help Ukraine group website. So we have our next speaker, Marina Sokolovska. Dr. Sokolovska, please share your slides. And we will hold the questions till the end.
Have you seen my screen? Hello?
No, we don't know.
Okay, I'll try again. I need to type again.
We need medical physics help.
Yeah. That- Okay. Is it okay?
Yeah, great.
Okay, thank you very much, Dr. Fuller, for the excellent presentation. We learned a lot, and let me introduce now from Ukrainian side 2 short cases about the patient's history and treatment. First case, it's a male, 51 years old, with squamous cell oropharyngeal carcinoma that was situated in the left palatal tonsil, and it was covered by biopsy in the February this year. Clinically, it was T3N0M0 and grade 2. A patient is smoker more than 20 years. In March, it was provided clear treatment to the tonsil in the clinic. I don't know where, but it was suspicious procedure without result. And patient after that received 3 cycles of chemo, paclitaxel and carboplatin, and finished in the April this year without clinical improvements. As it was hard to us that wasn't provided any imaging before the chemotherapy on CT or other types. MRI is impossible to this patient because he has metal peel in fingers. And the PET-CT wasn't provided as well due to a huge queue for this imaging, because currently this time only one PET-CT centers works in Ukraine. Patient came to our clinic, and in May of this year, we constant the progression. Patient complains has complaints that he feel a tumor in the left side of oropharynx and tongue, and visually it was a huge tumor. He has acute pain that has a 7 or 8 point by west, and irradiation this pain into the left ear, and he has articulation disorders. We provided CT in the end of the May, and it was confirmed the progression. The clinical, it was locally advanced tumor T4N2M0. As you can see on this photos, it ulcerative tumor lesion in the left side of oropharynx and spread to the tongue, and from left side it's spread to the right side more than 3 centimeters. Involved base of tongue. We fixed our radiologist fixed the contact involvements of the lower jaw in the lateral muscles in the left submandibular gland, and the caudal margin reached to the vallecula of the epiglottis on the left. And about lymphadenopathy, it was increased lymph nodes on the left in the 2A level up to 35 millimeters, and on the right 2A and B region involved. Just a second. We decided on the tumor board that the patient have started the definitive radiotherapy in 70 grays in 35 fractions with concurrent cisplatin 100 milligrams per square meter every 3 weeks. We divided the tumor, the treatment volume for the 3 sites of PTV. It's low risk 54 grays, intermediate risk 60 grays, and for high risk it's 70 grays. So it's the sequential boost. We treat our patients with head and neck on VMAT with daily CBCT. And on this slide, I try to show how the volumes, we control the volumes delineation. So GTV for the primary tumor, it's a green one, and the purple one, it's the nodes, involved lymph nodes. In the left side, it's a big more than 10 millimeters lymph node into A level, and in the right side it's a small lymph node. For the high risk, it's boost number 2. We will treat 10 grays in 5 fractions, and it would be only involved sites tumor and lymph nodes with the margins 5 millimeters to CTV and 3 millimeters to the PTV. For the first boost, intermediate risk 6 grays in 3 fraction, except the primary sites, it would be bilateral lymph nodes regions 2 and 3, and in the same CTV with the margins to PTV 4 millimeters. And for low risk PTV, we cover Oropharynx, bilateral lymph nodes from 1A and B till 5 levels, retropharyngeal lymph nodes, and for CTV we add 5 millimeters for PTV. And the questions in this case would be, how would you treat this patient? Management, I'm interested more about management of dose distribution. Is it simultaneous integrated boost will be suitable in this situation? As the tumor is quite big and the volumes big as well, so it's predictable that toxicity would be quite high. The toxicity management you described previously, but maybe in this case you will give some recommendation. We recommended to this patient to put back during the treatment, that it would be the necessity of this. We recommended to start supplement food from the start of the treatment, and he advised before the treatment to provide sanation of the oral cavity, because he has a lot of teeth with the caries. What diagnostic methods I essentially you covered as well, but how we could treat the patients without PET-CT, the margins, as I know that for the PET-CT using for the fusion, we could use the treatment strategy 5+5, but when we have no precise information about the spread of the tumor, we could have wider margins, 1 centimeter for the CTV and half centimeter for the PTV. Maybe you have other recommendation. And what is the contouring and dose prescriptions recommendation would be for this patient as well. And in Ukraine, we still have a lot of cobalt machines. Is it feasible to treat the patients with head and neck without gaps? Because it's quite, I would say, interesting question, because in other cases, patient wouldn't have any treatment possibility. But only cobalt, it's some type of treatment in this situation. And maybe we have a time for these questions later or now.
I think it's good to answer now. Dr. Fuller, do you want to take it on?
Yeah, I mean, so, so we were talking about this when we were having the meeting before, unfortunately, cobalt-60 is not something that has been widespread in the U.S. in, since really the 90s. So I'll be honest with you, I have not treated with cobalt in my career. We are maniacally against treatment breaks. So there was a study by Karen Fu in the 90s that showed that treatment techniques that involved a 2-week break had a substantial increase in the rate of recurrence. And we know radiobiologically that repopulation occurs. So we really do everything we can to prevent breaks, right? So we often will inpatient hospitalize patients if they need fluid support or nutritional support, and then bring them down in their bed so that we don't have to break treatment. We really feel strongly that breaks in treatment are really compromising, local, regional, and ultimate tumor control. That said, I mean, I think that in the pre-LINAC era, that was something that happened routinely, right? So I think where you're stuck is, I would do everything you can, massive, aggressive nutritional support during the initial phases of therapy, the most aggressive pain control you can imagine, PEG tubes if you need them, hospitalization if you need them. But we would literally, unless the patient's on a ventilator, we're going to treat that day. We just are maniacal about it. So I don't know if that's a good answer, but that's kind of our philosophy.
And there are other questions. How would you treat the patient that Dr. Sokolovska presented? Would your approach be similar to contouring targets?
So yeah, so our contouring of targets is anatomic. We do a mid-therapy adapt at fraction 10 to 15, where we account for weight loss and we account for tumor shrinkage. I think that's analogous to what you're kind of doing, that adaptation. I like the adaptation that was done because you guys are adapting in the boost phases, right? So I think one of the things that you're seeing is these boost phases for y'all, are like an adaptation for us. So we do an SIB so that we can have a comprehensive idea of what the dose is and really push off these OARs on the front end. But that's just kind of our, a lot of folks in the U.S. still use sequential boost techniques. The dose prescription, cumulative dose prescription, looks very similar to what we would do. If PET-CT is not available for us, the best next thing is really MRI. So a CT in immobilization with contrast then the next best thing we try and get is a PET CT. If you can't get a PET CT, the next best thing is an MRI, right? And we really heavily rely on diffusion-weighted MRI as a kind of alternative, a kind of poor man's PET. So if you have a good DWI sequence, you get good contrast to noise between the tumor and nodes, and you fuse that to your MR or CT, and it's not a PET, but it's not bad. So we tend to use that a lot. You know, contouring and dose prescriptions, you know, our contours and dose prescriptions don't change much when we lack imaging information, but our margins sure get bigger, right? So we don't really finesse the doses, but suddenly, you know, the more uncertainty you have in whether you can localize it on the sim, whether you can localize it physically, whether you can localize it on IGRT, whether you can localize it with immobilization, every time that uncertainty gets larger, my volumes that I draw get bigger, right? So we don't really account for it by changes in dose prescription. We're just more generous to not mess, right? So, you know, part of what we're trying to do when we talk about this organ sparing is, you know, the more certainty you can get from the scans you have at simulation, the IGRT system, the certitude of the immobilization, a good scope exam that tells you where the edge on the mucosa. All those things help us drive away, but you always got to cover the tumor first. And if it's a choice between toxicity reduction and missing tumor, cover the tumor.
Yeah, very good. One question I have, when you build your CTVs, do you shave off bone?
Yeah. I'll show
You
you.
go back?
Here,
Yeah.
just a second. No, unfortunately, it's
Go back? Yeah. Mhm.
yeah, for GTV and for CTV, we avoid their anatomical structures, bones, and air. But PTV, we covered this minimally.
And Dr. Sokolovska, you do IGRT every day?
Yeah, we have daily Conbeam CT,
Daily Conbeam.
and for this patient, unfortunately, we couldn't provide any PET CT and MRI, so we have only CT.
Okay, thank you. Maybe start with case 2.
Yeah,
that's great.
The case 2 dedicated to the problem of decreasing patient's volume in the treatment area and replanning of this area. So we treated the male patient, 65 years old, with squamous cell P60 positive carcinoma of base of tongue. And clinically, it was stage T2 and 2B, M0, and grade 3. He finished his course of definitive radiotherapy in 70 grays 35 fractions with radiosensitization cisplatinum only 2 infusion, and the second one was with carboplatin due to ototoxicity. The treatment strategy with the sequential boost was as well the same. And the contouring was with the fusion of PET-CT. But in the more than in the middle of the treatment, patient started he has the difficulty of swallowing, and despite that we put the gastrostomy, he keep losing his weight. And as we saw on our daily CBCT, the volume of the neck decreased. On the upper photo, you can see that the green contour of the tumor, it's the primary tumor, and the red and the lymph node in the right of the neck, it's a 2B level. And the red one, it's the new contour, because we did red simulation and replanning before the boosts, and recontour because we could have a geographical miss in the target volume covering, and moreover that organ at risk shifted more. We scared about the those to the parotid, and because of the red simulation and replanning was before the boosts, during the first course of the low dose volume, we treat this patient without any breaks in treatment. And currently, the patient 3 years in remission. On the June this year, he came to us, and after the endoscopic examination with results of PET-CT, without patient without any signs of recurrence, but he has post-radiation hyperthyroidism and post-radiation fibrosis of soft neck tissues. And I have a few questions, the list of questions. You told us previously about the resimulation and replanning. How frequent is in your practice, Dr. Fuller? The reason you told us about dose escalation, we have information. And what are pros and cons of the SIB? What is essential to know when we have to evaluate DVH and those constraints with SIB? When we can perform a unilateral neck irradiation, and indication, as I remember, it was covered. And the question, if we detect a few small pathological lymph nodes up to 10 millimeters that enhance the contrast on the CT or MRI, what is the tactic of dose prescription for low and high dose CTVs? We need to treat this lymph node separately with additional margins for CTV from GTV, or we could treat as a whole level, and if yes, in what dose? And the question about the decrease in the dose and volumes for senior patients, is it useful, and how we could do it? Thank you.
Yeah. So reflecting on these questions, you know, we resimulate every patient between fraction 10 and 15, because if you're going to do one resimulation, that's when you get the most bang for your buck. If you resimulate too late, there's no things to change. If you resimulate too early, they haven't lost any weight. So 10 to 15 is when we resimulate. And then, and for most patients, that's really just accounting for weight loss, unless they have a big tumor that's really regressed. A small number of patients, if we see that on the CBCT, or if we see that their mask is getting too loose, we'll do another resim somewhere between week 4 and 5, but that's atypical. In terms of dose de-escalation, we don't routinely dose de-escalate off clinical trials, but what we do is de-intensify for small volume P16 disease by dropping the chemotherapy. So again, like we talked about, if you've got, you know, T1 to 2, 1 to 2 nodes, no extracapsular extension, the nodes are small, they have a limited smoking history, less than 10 pack years. Those are patients you can de-intensify, but we don't drop the radiation dose much. In terms of the other questions, you know, one of the ones is for these small nodes, if, you know, what dose do you treat them to? We will routinely treat them to 66 gray with a margin that's dependent on your IGRT system. But the issue you bump into is if you have a little node next to a big node, you're not really sparing much. And so if the little node is next to a big node, we just cover it with a 70. If there's a lot of little nodes together, we just group them as one volume. It kind of depends how spaced out they are. Now, the problem you bump into is if you have nodes running all the way down level 2, 3, and 4, those polynodal patients have already shown you that they have a pretty aggressive metastatic profile, even at low volume disease. So even if the dose isn't extensive, your kind of coverage of those regions is because you can suspect that their low neck risk is elevated, right? So the spatial distribution of the nodes matters as much as the number and the size, right? Finally, that last one about senior patients, we don't really, unlike Europeans, we don't have age thresholds. We really look at performance status. And we try and be as aggressive as we can be given the patient's performance status. So one of the reasons that we really like weekly cisplatin is you can give low-dose platin, and if the patient starts to develop renal toxicity or ototoxicity or really fall into disrepair, you just stop the dose. And you've escalated as much as you can without crumping them out with that second high-dose platinum. So a lot of times we'll do is modulate the chemotherapy first based on their performance status. And then if that doesn't work, now we drop the chemo, but we really try and go as aggressively as we can, given the patient's population. If we can't go aggressive and we really can't deliver curative intent therapy, we tend to shift wheels and go to palliative intent therapy, right? So we don't really have a middle ground, and that's really just more our concept. We kind of either go for high dose and high probability of cure, or we move to more of a palliative, short course, low toxicity regimen because that patient's just not going to be a curative candidate. And there's not a great reason for that. I know a lot of folks in the UK use these kind of intermediate dose quasi-curative regimens. We don't really do that.
Thank you so much. We see some questions in the chat. In addition to these questions, if we use NG tube, do we need to correct the radiotherapy plan?
So for most NG tubes, the answer is no, unless you see that the NG tube is causing displacement of a structure on your cone beam CT or your IGRT system. So as long as your IGRT platform is setting up, your margins are appropriate, you're not seeing errors in your setup, we typically don't make a full replan for NG tube placement. That said, we will often replan if the patient has massive weight loss. So we're really replanning for the weight loss, not replanning for the NG tube itself.
Okay, great. Do you have any advice for immobilization patients with a history of epilepsy?
No, but that's a good question. I mean, if a patient goes into a grand mal seizure, I don't know that any of our masks are going to solve that problem. So I would say, there you're talking about medication optimization and maybe even utilization of sedatives, as opposed to, I think that seems to be more of a medication management issue than an immobilization one, right? We've had patients who have like essential tremor, and those can be handled very well with aggressive immobilization, but epilepsy is the one we really just get your drugs. If a patient seizes during a treatment, you're going to stop the treatment, treat the seizure, right? I don't think I'd be very uncomfortable just treating through a seizing patient.
Right. I agree. What are the indications for using nasogastric tube or PAC tube?
So our rule of thumb, right, in a very basic way, is 2 kilograms is a weight loss of 2.5 kilograms 2 weeks in a row. That just tells you that the patient's in free fall. They can't arrest their nutrition. And so no matter where that happens during therapy, some people like to use these body weight formula. In the US, that doesn't work very well because a lot of our patients are, to be fair, obese. And so they can lose huge amounts of percentage body weight, even though they've been in like massive nutritional free fall. So we use an objective threshold of 2.5 kilograms, 2 weeks in a row, throw an NG tube in it.
Oh, that's a good rule. Do you perform SBRT treatments for advanced oropharyngeal carcinoma or for patients with poor prognosis?
No, we use SBRT primarily for re-radiation cases. So
Right.
there you're really looking for high dose gradient patients where you're really trying to get over the biological edge of the therapeutic response in a tight gradient. We have not used those in the upfront setting. Again, if we have a patient who's not a candidate for curative intent fractionated radiotherapy, we won't do SBRT, but we'll do SBRT-like hypofractionations, quad shots, 36 and 6, but it's not curative intent. We're really just trying to palliate.
Oh, that's great. What is the preferred dosing and technique for re-irradiation, and if possible to combine cisplatin cetuximab?
Okay, so this is a really good question. So I'll talk to you. This is kind of a conceptual idea. So how you manage re-radiation cases depends immensely on where the recurrence is, where it is relative to the previous radiation dose, and what the surgical options are. So if you have an isolated recurrence in the neck, we almost always do surgery first. Your real goal is cytoreduction before re-radiation. So if you can do surgery, you do surgery. If you can't do surgery, we will do induction chemotherapy or induction immunotherapy, try and volume reduce. And if the volume is small enough, we'll try and stereo it. If it's like an isolated RP node or an isolated node or a very small recurrence, we'll treat the post-induction chemo volume with SBRT if we can. If not, then we would re-irradiate to, again, as close a dose as we can get. But if you don't have a way to cytoreduce either surgically with immunotherapy or with chemotherapy, these patients don't do well. A patient who's failed standard fractionated radiotherapy in the high dose region of the field, repeating that a second time to resistant clonogens doesn't go well. So you've got to either cytoreduce through surgery, cytoreduce through chemo, cytoreduce through immunotherapy, and then try and get a stereo plan or a post-op plan if you can. We use protons a lot. We use MR-Linac a lot. We use stereo a lot. But every re-radiation case is its own genre. A patient who has a radiated neck and has a recurrence 10 years later is a different animal than a patient who has a recurrence 10 months later. They're just objectively night and day.
Yeah, and there's actually going to be a lecture on re-irradiation. Will be quite general, but this is a very interesting topic and not very well discussed, right? But we'll have a lecture on this topic. There's also one question about unilateral treatment. What cases do you treat unilaterally?
So we treat all tonsils that don't have, so if you have a tonsil that's that doesn't involve so if a tonsil doesn't involve the base of tongue, if it doesn't go onto the posterior pharyngeal wall, if it doesn't go over the lateral third of the soft palate, we safely treat those all the time. If you have invasion, if 2/3 of the soft palate's involved, we treat bilateral. If you have base of tongue involvement, that's a direct base of tongue, we treat bilateral. If you have pharyngeal wall, like coming across the entire pharyngeal wall, you need to cover bilateral. So we kind of use those as our rough metrics for unilateral cases. Some places will do very lateral base of tongue tumors. Also do bilaterally. We feel a little bit uncomfortable with that, but I don't think it's a wrong answer. So what I would say is highly lateralized, tonsillar cases are the ones we go with.
Excellent. I would like to ask also about SIB. So you mentioned you prefer SIB in your clinic, and what's the benefits, pros and cons of SIB treatment?
So I think, Marina and I were kind of talking about this. So we like SIB because you really are maximizing the low dose. You're maximizing your probability of accounting for your low dose coverage in your initial plan. So one of the problems that happens is if you have your initial plan as an SIB, you're always having to, you're having to think about uncertain information that's additive as you're moving through time, right? So with the SIB, it's a little cleaner in terms of understanding what you're doing because you have a complete plan in front of you. You've optimized the hell out of it on that initial one. And then if you have to go back and replan, you're re-optimizing the hell out of the new plan, but accounting for all the dose levels. So that's the rationale that we kind of like for SIB. We know folks, and we've talked with folks, we have friends who do, especially in places like China, where they're really trying to get those patients into treatment rapidly for things like nasopharynx, where these things grow incredibly quickly, where they're starting with a like very generalized, simple plan, so they can just get the patient on the machine, and then they're fixing or modifying the dose on the boost plans afterwards. So I think, a lot of places that do SIB, it's driven by logistic concerns, dosimetrist access, your planning practice, things like that, rather than, a strong dosimetric rationale. But SI plans, we like them. They're just kind of cleaner conceptually for us to deal with on the front end. The other nice part is if you go into ADAPT and the patient doesn't lose weight and they don't need changes, then you really have this optimum plan and you just continue it on. So I think that's kind of why we favored it. But I don't think there's a right answer there. I don't think there's, many of the studies we've treated recently, ECOG 3311 used a sequential boost technique. You could get plans that really approximated the SIB plans if you have a good dosimetrist. So I don't feel it's something where it's a, I wouldn't say there's a right or wrong answer.
Okay, thank you so much. So I would like to invite the audience to turn on the mic and the camera if you would like to ask a question live. And I see Marina has a very nice slide thanking.
Yeah. I want to express our thanks to the Professor Fuller, to the Professor Tamer Rafat, and especially to you, Natalia, for the organization, for great opportunity for Ukrainian radiation oncologists to learn modern principles of radiation oncology. Today it's oropharyngeal cancer, and it was a great talk and a lot of useful practical information from Dr. Fuller. So thank you a lot for this opportunity. As I wrote you previously, together we will make a difference. And for Ukraine, it's very important nowadays. Thank you very much.
Thank you, Dr. Sokolovska. It's very nice, kind of you, and you're right. Together we'll make a difference. Thank you. So I see Dr. Shapil, you turn on the camera. I would like to ask a question.
Yes, I have some questions. Thank you very much for interesting information. The information very useful for us. I have some questions about advanced cancer or when we have invasion of big vessels, for example, for carotid. What your treatment options on this for this patient, and if we have some situation when chemotherapy is impossible because the patient have toxicity complication after receiving chemotherapy, what your treatment plan for this patient? Thank you very much.
Yeah, so in the first case, when you have these massive locally advanced disease with carotid artery, either full invasion or full circumferential involvement, we typically in those cases will our interventional guys will stent those patients in some cases prophylactically, right? Because we do worry about if you see that vessel wall's eroded and you start to treat, you're just risking blowouts. So we really kind of prep our cardio oncology guys and get them ready that this is a case that may go that way. There are cases where we have tried induction chemotherapy as a way to kind of gradually reduce that volume and see if we can get the tumor to pull off the carotid if it's not circumferential. But it's just a tough case, and at the end of the day, you end up treating it and letting the patient know you're at extremely high risk, and your options are exsanguination through tumor invasion or exsanguination through radiation-induced rupture, and it is what it is, right? But that's a tough one. Regarding patients who don't tolerate chemo, there's a lot of layers for don't tolerate chemo. Where I trained, we gave 100 milligrams per meter squared, and everybody did okay the first round, and then we gave it the second round, everybody crumps out, and they're just torched, right? They do really badly. You're potentially hospitalizing, or they're missing fractions or what have you. Here at our place, we start with 30 to 40 milligrams cisplatin on a weekly basis. So if the labs drop, the patient does badly, you can hold for a week and then resume. If it's clear that the patient can't tolerate the cisplatin, you can then switch to carbo or even low-dose taxanes as a way to preserve radiosensitization, but just down, kind of down manage. So there's a world of difference between, we typically don't say don't tolerate, stop as a binary choice because we're doing lower doses at more frequent intervals. And so for us, if you say, okay, I'm not tolerating cis at 40, let's try it at 30. Okay, you can't tolerate at 30. Let's try it at 20. Okay, let's move to carbo. Okay, you can't tolerate carbo. Let's move to a low-dose taxane. So we can kind of, modulate that as they go through therapy. And if you need to hold, the last week or last 2 weeks of weekly cis, at least you've gotten in as much area under the curve in terms of, radiation sensitization as you can, right? Now, if a patient walks in and they're clearly not a cis candidate, then you go, okay, let's try cetuximab, right? And load with cetuximab. And then if they start to develop toxicities after that, rash gets bad, they can't handle what's going on there, then you just hold those weekly doses in a similar way. So that's kind of philosophically how we would think about that. I don't know if that's a good answer, but that's kind of approach.
Yeah, that's a pretty good answer. If there are no more questions, I would like to invite people to turn on their cameras. We'll take a group photo. This is our first lecture, so it's a historic moment. So let me, yeah, great.
And thank you guys. I know it's late over there, so thank you for
it's
putting up
very
with
late.
our time difference.
And you see some of them don't have any electricity, so you could see no light. It's because of missiles attacking energy infrastructure. So regardless, despite of all, Ukrainians join. So which is quite amazing. Thank you everyone for joining. I'll say smile. Great photo. I got a great photo. Okay, everyone. Very nice to see you all. Thank you so much, Dr. Fuller. Thank you so much, Dr. Sokolovska. Thank you so much, Dr. Rafat. It was a great success today. So we'll continue with that tempo or rhythm. And I will be sharing the recording of this lecture, and also we'll be translating it into Ukrainian, and I will share the links. Excellent. See you next month. Bye, everyone.
And thank you all for all what you do in Ukraine. Thank you very much. Bye.
Bye.
Thank you very much.
Добраніч.
Добраніч.